Welcome, future nurses. We're so glad you're here. Today's topic is pharmacology of blood and blood products, a vital area that every NCLEX test taker must master. In this video, we'll break down everything you need to know, from anticoagulants and clotting factors to transfusion reactions and blood safety protocols. We're covering 15 powerful NCLEX-style questions, each explained in detail to help you think like a nurse and build strong clinical judgment. And remember, we bring you a new high-yield NCLEX topic every single day, designed to keep you ahead in your prep and closer to your nursing license. So hit that follow button, stay with us until the end, and let's make your NCLEX prep smarter, faster, and stronger, starting right now. Right before we get into the question, let me ask you this. Is your NCLEX prep complete? If not, the Complete NCLEX Review course gives you 100 hours of animations, 500 hours of lecture content, 5,000 high-yield questions, 500 NGN case studies, and 15 mock exams, all with a year-long ebook. Save 70% today, but the deal won't last. Click the description link to enroll and start strong. Let's dive right into an essential topic for the NCLEX, especially one that often appears in medication safety and client education. Let's dive right into it with question number 1. The nurse is preparing discharge instructions for a client who has been prescribed phenazopyridine to manage discomfort associated with a recent urinary tract infection. Which statement should the nurse include during client education? Now, let's go through the choices together so you can carefully analyze what makes one option stand out. Option A. Be sure to report any darkening of the urine immediately, as it could signal kidney damage. Option B. You should avoid wearing contact lenses while taking this medication. Option C. This medication must be continued for at least 7 days to clear the infection. Option D. You may notice a reddish-orange discoloration in your urine while taking this medication. All right, take a moment and think like a nurse preparing a client for safe medication use. Let's break this down with what you absolutely need to know. The correct answer is Option D. You may notice a reddish-orange discoloration in your urine while taking this medication. Now, here's why that choice is absolutely the one to remember. Phenazopyridine is not an antibiotic. It is a urinary tract analgesic used for relieving discomfort, such as burning or urgency associated with urinary tract infections. One of the most well-known and expected effects of phenazopyridine is the reddish-orange discoloration of the urine. This is completely harmless and simply results from the azo dye in the drug. It is not a sign of kidney damage, and in fact, clients should be reassured that this is temporary and nothing to worry about. On the other hand, option A is incorrect, because although the urine changes color, this is not an indication of renal damage and should not alarm the client. Option B may seem partially true since phenazopyridine can stain soft contact lenses due to excretion through tears, but avoiding contact lenses is not a standard or critical teaching point. It is not as relevant as informing the client about the urine discoloration. Option C is inaccurate because phenazopyridine does not treat infections and should not be used for more than 2 days, especially when taken with antibiotics. Using it longer could mask the progression of the infection. This kind of teaching is a must-know point for NCLEX, especially because it reinforces the distinction between symptomatic relief and actual antimicrobial therapy. So always remember, when it comes to phenazopyridine, your client should be told to expect that reddish-orange urine and not to be alarmed. Let's continue sharpening your clinical judgment with another high-yield medication safety scenario for NCLEX. Let's put your knowledge to the test with question number 2. The nurse is administering a 40 milliequivalent dose of potassium chloride to a client who has been diagnosed with hypokalemia. The medication is supplied in capsule form, but the client expresses difficulty swallowing large pills. What is the most appropriate action the nurse should take to ensure safe and effective administration of this medication? Let's carefully look at the choices to determine which intervention aligns with both safety and best practice. Option A. Open the capsule and sprinkle the contents onto a spoonful of cool soft food like applesauce. Option B. Request that the client break the capsule into smaller pieces and swallow each one with water. Option C. Dissolve the capsule contents in a small amount of warm milk and administer immediately. Option D. Place the capsule contents under the client's tongue to allow for buccal absorption. Now let's think through each of these based on what is safest and clinically recommended. The correct answer is Option A. Open the capsule and sprinkle the contents onto a spoonful of cool soft food like applesauce. This is the safest and most appropriate action, because many potassium chloride capsules are specifically designed to be opened and the contents sprinkled on soft food like applesauce or pudding, as long as it is cool or room temperature. This method maintains the medication's intended release characteristics and avoids the danger of choking, especially in clients with swallowing difficulties. The mixture should be swallowed immediately, without chewing, and followed with a full glass of water to minimize gastrointestinal irritation. Now let's discuss why the other options are incorrect. Option B is not safe, because potassium chloride capsules should never be broken. The capsule's outer coating is designed to control how the drug is released. Breaking it could lead to an immediate release of concentrated potassium, which can irritate the gastrointestinal tract or even cause ulcers. Option C may sound plausible, but dissolving potassium chloride capsule contents in warm milk is not recommended. Heat can accelerate drug dissolution, potentially causing burns or upper gastrointestinal irritation. Milk can also interfere with how the drug is absorbed. Option D is dangerous because potassium chloride is not formulated for sublingual or buccal absorption. Placing this medication under the tongue can cause painful burns and tissue injury. This route is absolutely inappropriate for this drug. This question highlights the importance of administration technique and understanding the formulation of high-alert medications like potassium chloride. So always remember, when the client cannot swallow potassium chloride capsules, opening them and mixing with soft, cool food is your safest and most effective go-to strategy. Let's move into a critical pharmacology question that focuses on medication safety and drug interactions, especially with anticoagulants, a favorite topic on the NCLEX. This one's important. Do not miss question number 3. The nurse is reviewing the home medication list of a client recently prescribed warfarin for atrial fibrillation. Which of the following concurrent medications, if noted on the client's list, requires immediate follow-up with the primary healthcare provider due to a potential drug interaction? Now let's explore the choices carefully and see which one could potentially interfere with warfarin's anticoagulant action. Option A, echinacea taken daily for immune support. Option B, saw palmetto used for benign prostatic hyperplasia symptom relief. Option C, amlodipine prescribed for hypertension management. Option D, calcium carbonate taken for occasional acid reflux. So let's unpack this and think like a nurse who is evaluating drug safety risks. The correct answer is Option B, saw palmetto used for benign prostatic hyperplasia symptom relief. Here's why this one is so important to catch. Saw palmetto is a common herbal supplement, and while many clients take it for urinary symptoms, it actually has mild antiplatelet effects. When combined with warfarin, an anticoagulant that already affects clotting, this combination can significantly increase the client's risk of spontaneous bleeding. Because warfarin has a very narrow therapeutic window, even mild changes in clotting balance can lead to dangerous outcomes. The nurse must notify the healthcare provider right away to reassess whether the client should continue using saw palmetto or whether additional monitoring, like more frequent international normalized ratio checks, is needed. Let's quickly review why the other options are not correct. Option A, echinacea, does not significantly impact warfarin levels. While it may influence liver enzymes slightly, it is not known to cause bleeding or potentiate warfarin in a clinically meaningful way. Option C, amlodipine, is a calcium channel blocker commonly used for blood pressure management. It does not interact with warfarin and is considered safe to use concurrently. Option D, calcium carbonate, is an over-the-counter medication for acid reflux and calcium supplementation. It has no known impact on warfarin's mechanism or effectiveness. This question highlights why a detailed medication history is essential, especially for clients on warfarin. Herbal and over-the-counter medications can seem harmless, but they may interact in unexpected and clinically significant ways. Always remember, for the NCLEX and real-life practice, herbal supplements like saw palmetto, garlic, ginkgo biloba, and ginseng should be closely evaluated and discussed with the provider when a client is taking warfarin. Now let's shift gears into a high-alert medication often used in emergency cardiac and respiratory conditions, loop diuretics. Time to apply your critical thinking. Question number 4. A client with acute pulmonary edema has received an intravenous dose of bumetanide as prescribed. During reassessment, the nurse evaluates the client's response to the medication. Which of the following findings would most likely indicate an adverse effect related to the administration of bumetanide? Take a look at these findings and think critically about what signals a complication versus a therapeutic response. Option A, blood pressure decreased from 138/82 to 110/70 millimeters of mercury. Option B, heart rate increased from 88 to 104 beats per minute. Option C, the client reports cramping pain in the lower legs. Option D, the client voided 950 milliliters within 2 hours after administration. Now let's unpack these one by one and determine which is most concerning. The correct answer is option C. The client reports cramping pain in the lower legs. This is a red flag for a possible electrolyte imbalance, specifically hypokalemia, which is a common and serious adverse effect of loop diuretics like bumetanide. Bumetanide works by blocking sodium and chloride reabsorption in the loop of Henle, leading to increased urine output. However, along with fluid loss, it also causes loss of key electrolytes such as potassium and magnesium. This can manifest as leg cramps, weakness, or more severely, cardiac dysrhythmias, if not caught and corrected. So when a client complains of cramping after receiving a loop diuretic, it should immediately prompt the nurse to evaluate serum electrolytes and notify the healthcare provider. Let's review why the other options are not considered adverse effects. Option A, a drop in blood pressure from 138/82 to 110/70, is actually a desired outcome. In cases of fluid overload, this type of reduction helps relieve cardiac workload and reduce pulmonary congestion. Option B, a mild increase in heart rate, may be a compensatory response to intravascular volume loss. While it should be monitored, it is not in itself a sign of harm unless it progresses to symptomatic tachycardia. Option D, producing 950 milliliters of urine within 2 hours, is exactly what we want in pulmonary edema. That level of diuresis shows that bumetanide is working to remove excess fluid from the lungs. The key NCLEX takeaway here is to always monitor for signs of electrolyte disturbances after administering a loop diuretic, especially muscle cramps, changes in mental status, or arrhythmias, and respond promptly to prevent serious complications. Here comes another key pharmacology question that tests your understanding of how medications influence electrolyte balance, something the NCLEX loves to focus on. Keep that momentum going. Question number 5. A nurse is reviewing laboratory results for a hospitalized client and notes a serum potassium level of 3.2 milliequivalents per liter. Upon evaluating the client's current medication list, which of the following prescribed drugs is most likely contributing to this electrolyte abnormality? Let's walk through the choices together and look for the one that most logically explains the low potassium level. Option A, hydrochlorothiazide prescribed for blood pressure control. Option B, losartan prescribed for chronic hypertension. Option C, prednisone prescribed for a recent asthma exacerbation. Option D, eplerenone prescribed for heart failure management. Now let's break down what each of these drugs does and see which one best accounts for the hypokalemia. The correct answer is option C, prednisone prescribed for a recent asthma exacerbation. Prednisone is a corticosteroid, and at therapeutic doses, it mimics the action of aldosterone, a hormone that promotes sodium retention and potassium excretion by the kidneys. This effect is particularly notable during prolonged therapy or at higher dosages. As a result, prednisone can significantly lower potassium levels, leading to symptoms like muscle cramps, weakness, and even cardiac arrhythmias if left unchecked. That's why it is so important to monitor potassium levels and consider supplementation when a client is on corticosteroids. Let's clarify why the other options do not fit as well. Option A, hydrochlorothiazide, is indeed a thiazide diuretic that can cause potassium loss, and it would be a reasonable consideration. However, in this question, prednisone stands out as the medication with the clearest link to systemic potassium loss due to its mineralocorticoid activity. Option B, losartan, is an angiotensin II receptor blocker, and this drug actually tends to increase potassium levels by inhibiting aldosterone production. That makes it more likely to cause hyperkalemia than hypokalemia. Option D, eplerenone, is a potassium-sparing diuretic that works by blocking aldosterone receptors. Like spironolactone, it is associated with increased potassium retention, not loss. That means it also would not be the cause of a low serum potassium level. This question reminds us how essential it is to match laboratory data with a client's medication regimen. For NCLEX success and safe practice, always keep in mind which drugs raise or lower potassium, and know that corticosteroids like prednisone can quietly deplete potassium over time. Let's dive into an important electrolyte and renal regulation topic that often shows up on the NCLEX: understanding the delicate balance between calcium and phosphorus in chronic kidney disease. Let's see how well you understand this concept. Question number 6. A nurse is administering phosphate-binding medications to a client diagnosed with hypocalcemia, secondary to chronic kidney disease. Understanding the physiologic relationship between calcium and phosphorus. Which rationale best explains the purpose of giving a phosphate-lowering agent in this scenario? Let's explore the choices now and think about which explanation is most rooted in physiology. Option A, lowering serum phosphorus enhances calcium absorption in the intestines. Option B, reducing serum phosphorus allows for an increase in circulating serum calcium levels. Option C, phosphate binders stimulate parathyroid hormone to release stored calcium. Option D, calcium cannot be increased unless phosphorus levels fall below 2 milligrams per deciliter. Now let's break down the answer that truly reflects the physiologic relationship between these minerals. The correct answer is option B. Reducing serum phosphorus allows for an increase in circulating serum calcium levels. This is the key concept you want to take away. Phosphorus and calcium are inversely related. In chronic kidney disease, phosphorus builds up in the bloodstream because the kidneys can no longer excrete it efficiently. That excess phosphorus binds to calcium, forming insoluble salts that reduce the amount of free ionized calcium circulating in the blood. By administering phosphate binders, we help prevent phosphorus absorption in the gastrointestinal tract, which in turn lowers serum phosphate levels and allows more calcium to remain bioavailable. That directly helps to correct hypocalcemia. Let's go over why the other options do not apply here. Option A is incorrect, because calcium absorption in the intestines is primarily regulated by activated vitamin D, also known as calcitriol. Phosphorus levels do not directly influence intestinal calcium absorption in the way this option suggests. Option C is also incorrect. Phosphate binders do not stimulate the parathyroid hormone. In fact, elevated phosphorus stimulates parathyroid hormone secretion in chronic kidney disease, leading to secondary hyperparathyroidism. The role of phosphate binders is to limit dietary phosphorus absorption, not to manipulate hormone levels directly. Option D is not accurate because there is no fixed phosphorus threshold, like 2 milligrams per deciliter required for calcium levels to increase. Calcium-phosphorus balance is regulated by complex feedback systems involving kidney function, hormone signaling, and vitamin D metabolism. For NCLEX purposes, always remember that phosphate binders help reduce serum phosphorus, which in turn frees up more calcium in the blood. This is a fundamental concept in managing mineral imbalances in clients with kidney disease. Let's move into a very testable area of client education and safety, especially when it comes to diagnostic procedures involving contrast agents. You are doing great. Now take on question number 7. The nurse is preparing to educate a client who is scheduled to undergo an angiographic procedure using intravenous iodinated contrast media. The client expresses concern about potential side effects. Which of the following symptoms should the nurse explain is not an expected or routine response to contrast administration? Let's now take a close look at the options and think about which of these stands out as abnormal in the context of contrast exposure. Option A, a metallic taste in the mouth immediately after injection. Option B, a headache lasting several days post-procedure. Option C, a mild burning sensation at the intravenous insertion site during injection. Option D, a transient sensation of heat moving through the body. Now let's go deeper into the explanation so you can connect the right answer to real clinical reasoning. The correct answer is option B, a headache lasting several days post-procedure. This is not a routine or expected effect after contrast administration. While a very brief headache might occur immediately after injection and typically resolves on its own, a headache that lasts for several days could signal an underlying issue, such as a contrast sensitivity reaction, uncontrolled blood pressure, or even a vascular complication. This type of prolonged symptom requires follow-up and should not be brushed off. Now, let's talk about why the other options are considered normal and should be explained to reassure clients. Option A, that metallic taste in the mouth right after injection, is actually one of the most frequently reported side effects of iodinated contrast. It is harmless, short-lived, and resolves quickly without intervention. Option C, a mild burning or warm sensation at the intravenous site during injection, is also common due to the hyperosmolarity of the contrast agent. The nurse should always monitor for signs of extravasation, but if the intravenous line is patent, this sensation alone is not worrisome. Option D, the sudden wave of warmth or heat moving through the body, is a classic and expected sensation. Many clients describe it as a hot flash or sudden internal warmth, especially through the chest or groin. It typically lasts only a few seconds to minutes and is harmless. What makes this question so valuable for NCLEX preparation is that it highlights the importance of distinguishing normal client experiences from abnormal ones. When educating a client, always emphasize that brief warmth, strange taste, or mild burning is expected, but persistent or worsening symptoms like a prolonged headache are not normal and should be reported immediately. Hold on just a sec. Let's talk strategy. The complete NCLEX Review online course is your fast-track prep kit. 100 animated hours, 500 hours of lectures, 5,000 questions, 500 NGN-style case studies, and 15 exam simulations. All this plus a year-long NCLEX ebook. Act fast. It's now 70% off for a limited time. Visit our site using the link in the description and start today. Let's unpack a common discharge scenario involving phosphate binders, especially important for clients living with chronic kidney disease. Let's challenge your clinical judgment with question number 8. The nurse is providing discharge teaching to a client newly prescribed sevelamer for management of hyperphosphatemia related to chronic kidney disease. Which of the following statements by the client would indicate correct understanding of the medication and its administration? Let's now review each of the choices and think about which statement shows a proper grasp of how this medication should be taken. Option A, I should avoid taking this medication with food to prevent nausea. Option B, I should take this medication with my meal. Option C, this medication works best if I take it first thing in the morning on an empty stomach. Option D, this medication may cause me to retain fluid, so I will monitor for swelling. Now let's go over the correct response and understand why it matters. The correct answer is option B, I should take this medication with my meal. Sevelamer is a phosphate binder that works by attaching to dietary phosphorus in the gastrointestinal tract during meals, which prevents it from being absorbed into the bloodstream. This is crucial for clients with chronic kidney disease, where phosphorus tends to build up in the body. The medication only works when it is taken with food because that is when phosphorus enters the digestive system. If it is taken before or after meals, it cannot bind phosphorus effectively and becomes useless. Now let's look at why the other options are incorrect. Option A is wrong because avoiding food defeats the entire purpose of the medication. It is not meant to be taken on an empty stomach, and doing so will not prevent nausea. It may actually cause more gastrointestinal discomfort. Option C is a common confusion with medications that need to be taken on an empty stomach, but sevelamer is not one of them. It must be taken with meals to function properly. Option D is inaccurate because sevelamer does not cause fluid retention. In fact, it is not absorbed into the bloodstream at all. It works only in the digestive tract. The most common side effect to watch for is constipation, not swelling. So for NCLEX success, always remember this simple but crucial teaching point. Phosphate binders like sevelamer must be taken with food in order to work, and educating clients clearly about this can make all the difference in effective treatment. Let's now tackle another essential scenario involving sevelamer, but this time we are focusing on when to give it for maximum benefit, a detail that NCLEX questions love to test. Now here is something you might see on the real exam. Question number 9. A client with end-stage renal disease has been newly prescribed sevelamer to manage persistent hyperphosphatemia. The nurse is preparing to administer the medication. At which point should the nurse plan to give sevelamer to ensure maximum therapeutic effectiveness? Let's walk through the options and determine which timing aligns best with how this medication is designed to work. Option A, with the client's meals. Option B, 1 hour after completing a high-protein snack. Option C, during the initiation of the client's hemodialysis session. Option D, on an empty stomach before breakfast to improve absorption. Now, let's walk through the logic and figure out which response is clinically accurate. The correct answer is option A, with the client's meals. This is a critical concept. Sevelamer is a phosphate binder that works only when it is present in the digestive tract at the same time as dietary phosphate. When taken with the first bite of food, it binds to phosphate in the gastrointestinal tract, reducing its absorption and helping control serum phosphate levels in clients with chronic kidney disease. This is why it must always be given with meals, not before or after. Let's review why the other options are incorrect. Option B, giving the medication 1 hour after a high-protein snack is too late. By that time, most dietary phosphate has already been absorbed into the bloodstream, making the medication essentially useless. Option C, during the start of hemodialysis, is a common misconception. Sevelamer works in the gut, not in the bloodstream, and has no relationship with dialysis timing. Phosphate removal during dialysis occurs through filtration, not by oral binders. Option D is incorrect because sevelamer is not absorbed into the bloodstream, so there is no benefit to taking it on an empty stomach. In fact, taking it without food makes it ineffective because there is no dietary phosphate available for it to bind. The key takeaway for NCLEX is this. Phosphate binders like sevelamer must be taken with meals, because that is when dietary phosphate is present for them to work. Proper timing is everything when it comes to maximizing therapeutic benefit in clients with chronic kidney disease. Shifting gears now into the world of intravenous antibiotics. This next question highlights a medication that's highly effective, but also carries significant risk if not monitored closely. Another step closer to NCLEX success. Question number 10. A hospitalized client diagnosed with acute bacterial cystitis is started on intravenous gentamicin therapy. To reduce the risk of serious adverse effects associated with this medication, which of the following parameters should the nurse prioritize monitoring during treatment? As you consider these options, focus on which one directly relates to gentamicin's most well-known complications. Option A, serum creatinine levels. Option B, liver enzyme values, including alanine aminotransferase and aspartate aminotransferase. Option C, capillary blood glucose trends. Option D, skin integrity and signs of peripheral neuropathy. The correct answer is option A, serum creatinine levels. Gentamicin belongs to the aminoglycoside class of antibiotics and is known for its potential to cause nephrotoxicity. Because of this, monitoring serum creatinine levels becomes absolutely essential. Elevated serum creatinine may signal that the kidneys are beginning to sustain damage from the drug, especially when administered in high doses or over extended periods. By keeping a close eye on this lab value, nurses can detect renal impairment early and help prevent irreversible kidney injury. Moving on to the other options, option B is incorrect because gentamicin is not hepatotoxic. Monitoring liver enzymes like alanine aminotransferase and aspartate aminotransferase is more relevant for medications such as acetaminophen or methotrexate. Option C is not appropriate either since gentamicin does not affect blood glucose levels. Unless the client has diabetes or is on another medication that influences glucose, this is not something you would routinely monitor. Option D, although it mentions neuropathy, is also misleading. While gentamicin may cause neurotoxicity at very high levels, especially affecting hearing and balance, it does not typically lead to peripheral neuropathy or affect skin integrity. What NCLEX wants you to recognize here is that gentamicin is associated primarily with nephrotoxicity and ototoxicity. So for safe and effective use, you must prioritize monitoring renal function, and that means watching those serum creatinine levels closely. Next, we move into fluid and electrolyte management, a core NCLEX topic that connects directly to safe medication administration and evaluating client response. Let's test your nursing instincts with question number 11. The nurse is caring for a client with a serum potassium level of 3.1 milliequivalents per liter. The primary healthcare provider prescribes 40 milliequivalents of intravenous potassium chloride to be infused over 4 hours. Which of the following assessment findings would best indicate a therapeutic response to the potassium replacement? Let's review each option and think about which one clearly shows that the treatment is working. Option A, new onset of paresthesia in the upper extremities. Option B, bradycardia and irregular heart rhythm. Option C, normoactive bowel sounds are heard upon abdominal auscultation. Option D, the client reports generalized fatigue and dizziness. The correct answer is option C, normoactive bowel sounds are heard upon abdominal auscultation. When a client is hypokalemic, gastrointestinal smooth muscle activity slows down significantly, often resulting in hypoactive or even absent bowel sounds. Potassium is essential for maintaining normal muscle contraction, including in the gastrointestinal tract. So, when you begin hearing normal bowel activity again, it is a strong sign that potassium levels are improving and that peristalsis has been restored. This is one of the most direct clinical indicators that potassium replacement therapy is having a positive effect. Now, let's look at why the other choices do not reflect a therapeutic response. Option A, new onset of paresthesia in the upper extremities, is more commonly seen in calcium or magnesium disturbances and is not a classic sign of improving potassium status. In fact, new paresthesia could suggest a separate issue altogether. Option B is concerning because bradycardia and irregular heart rhythm may reflect worsening hypokalemia or potentially an overcorrection, and absolutely require immediate assessment of cardiac rhythm and repeat electrolyte levels. Option D, generalized fatigue and dizziness, is far too vague to confirm whether the potassium therapy is working. These symptoms could be due to many different factors including anemia, dehydration, or ongoing electrolyte imbalances. For NCLEX success, always connect therapeutic signs of potassium replacement with improved muscle function, such as stronger bowel sounds, better cardiac rhythm stability, and improved muscle strength. In this case, the return of normoactive bowel sounds is your best clinical cue that the intervention is working as intended. Now transitioning into electrolyte management with a focus on magnesium, This question emphasizes early recognition of infusion-related complications. Something every NCLEX candidate should know cold. Focus in, this could be a potential exam question. Question number 12. A client is receiving intravenous magnesium sulfate to correct a serum magnesium level of 1.5 milliequivalents per liter, the lower end of the normal range. Midway through the infusion, the client suddenly reports facial flushing and warmth. What is the priority nursing action at this time? Let's go through each option and determine which intervention should come first to protect the client. Option A, administer a calcium gluconate antidote as prescribed. Option B, continue the infusion and apply a cool compress to the face. Option C, document the finding and reassess vital signs in 15 minutes. Option D, immediately stop the magnesium infusion to prevent worsening toxicity. The correct answer is Option D, immediately stop the magnesium infusion to prevent worsening toxicity. When a client receiving intravenous magnesium begins to experience facial flushing and a sudden warmth sensation, that is your first clue that magnesium levels may be rising too quickly, and toxicity could be developing. Stopping the infusion right away is the top priority because magnesium sulfate, if allowed to accumulate further, can quickly depress the central nervous system and cardiac function, leading to hypotension, bradycardia, loss of reflexes, respiratory depression, or even cardiac arrest. By halting the infusion promptly, you prevent the situation from escalating and buy time for further assessment or emergency intervention if needed. Now, let's talk about why the other options are incorrect. Option A may sound appropriate since calcium gluconate is the antidote for magnesium toxicity, but that is not your first step. Antidote administration is reserved for more severe cases involving serious symptoms like respiratory compromise or heart rhythm abnormalities. The priority here is to first stop the source of the problem. Option B, continuing the infusion while applying a cool compress, is unsafe and dismisses the seriousness of the early warning signs. Facial flushing during magnesium infusion is not simply a cosmetic issue. It can be the beginning of serious toxicity. Option C, waiting to reassess in 15 minutes and documenting the event, delays intervention and could allow the client's condition to deteriorate rapidly. For NCLEX success, remember this sequence. At the first sign of magnesium toxicity, whether it is flushing, nausea, or diminished reflexes, stop the infusion immediately. Always have calcium gluconate available, but act quickly to stop further magnesium administration before doing anything else. One quick heads up before we begin. If you're serious about passing the NCLEX, the complete NCLEX Review online course has every resource you need. 100 animated hours, 500 in-depth lectures, 5,000 questions, 500 NGN case studies, and 15 simulated exams. You'll also get a 1-year NCLEX ebook to study anytime. Right now, get 70% off. Limited time offer. Click the link below and take your first step toward passing. Switching back to chronic kidney care, this next question is all about evaluating whether phosphate binder therapy is doing what it is supposed to do. Let's walk through another key topic. Question number 13. The nurse is evaluating the effectiveness of sevelamer therapy in a client with end-stage renal disease and chronic hyperphosphatemia. Which of the following laboratory findings would indicate a therapeutic response to this medication? Let's explore each lab value and connect it with what sevelamer is actually prescribed to correct. Option A, stabilization of parathyroid hormone levels. Option B, increase in serum albumin concentration. Option C, normalization of glomerular filtration rate. Option D, decrease in serum phosphorus levels. The correct answer is Option D, decrease in serum phosphorus levels. Sevelamer is a phosphate-binding medication used in clients with end-stage renal disease because their kidneys can no longer excrete phosphorus effectively. It works by binding to dietary phosphate in the gastrointestinal tract, which reduces the amount that gets absorbed into the bloodstream. So, when you see phosphorus levels drop in the lab results, that is your most direct and measurable sign that the drug is working. Now, let's clear up why the other options are incorrect. Option A, stabilization of parathyroid hormone, might seem relevant because phosphorus and calcium levels do affect parathyroid hormone secretion. However, parathyroid hormone stabilization is not a primary indicator of sevelamer's success, as it often requires separate treatment with vitamin D analogs or calcimimetics. Option B, increase in serum albumin concentration, has nothing to do with sevelamer's function. Albumin is a marker of nutritional status, not phosphorus control. Sevelamer does not improve protein synthesis or influence albumin metabolism. Option C, normalization of glomerular filtration rate, is also incorrect because sevelamer does not improve kidney function. In end-stage renal disease, glomerular filtration rate remains very low, and phosphate binders are only meant to manage secondary complications, not to restore renal function. When preparing for NCLEX, always associate sevelamer with one key lab value, serum phosphorus. A drop in phosphorus confirms that the medication is achieving its intended therapeutic effect. As we move into parenteral nutrition, this next question focuses on central line safety and protocol adherence. Key skills every NCLEX test taker must master. This question is packed with testable content. Question number 14. A nurse preceptor is observing a newly hired nurse caring for a client who is receiving total parenteral nutrition through a central venous catheter. Which of the following actions by the newly hired nurse would require immediate intervention by the preceptor? Consider each choice in the context of safety, sterility, and standard procedure when managing total parenteral nutrition. Option A, cleans the catheter hub with chlorhexidine before accessing the line. Option B, maintains the total parenteral nutrition infusion through a dedicated central line lumen. Option C, primes and hangs a new bag of total parenteral nutrition without using an inline filter. Option D, monitors the client's blood glucose levels every 6 hours per protocol. The correct answer is Option C, primes and hangs a new bag of total parenteral nutrition without using an inline filter. This action is a serious safety concern because total parenteral nutrition solutions are rich in glucose, amino acids, and lipids, which create an ideal environment for bacterial growth and increase the risk of contamination or particulate embolism. An inline filter is necessary to reduce the risk of air embolism, infection, and crystalline precipitation. Administering total parenteral nutrition without this filter bypasses a critical layer of protection and puts the client at immediate risk, which is why the preceptor must intervene right away. Now, let's break down why the other actions are appropriate. Option A, cleaning the catheter hub with chlorhexidine, is actually an essential part of preventing central line-associated bloodstream infections and reflects best practice. Option B is correct because total parenteral nutrition must be administered through a dedicated central line lumen to avoid medication incompatibilities and reduce contamination risk. Option D, monitoring blood glucose levels every 6 hours, is also appropriate since total parenteral nutrition typically contains high concentrations of dextrose. Frequent glucose checks allow for timely insulin adjustments and help prevent hyperglycemia. For NCLEX success, always remember that total parenteral nutrition requires meticulous line care, dedicated access, close glucose monitoring, and absolutely must be administered with an inline filter to ensure patient safety. Time to focus on pharmacological management of urinary symptoms, a topic that blends perfectly with both medication knowledge and clinical decision-making for NCLEX. Let's take your knowledge one step further. Question number 15. The nurse is reviewing a client's medication regimen for the treatment of urinary urgency and incontinence related to overactive bladder syndrome. Which of the following anticholinergic medications should the nurse anticipate being prescribed for this condition? Let's go through each option and consider which drug has the right therapeutic target for bladder control. Option A, benztropine. Option B, glycopyrrolate. Option C, oxybutynin. Option D, tiotropium. The correct answer is Option C, oxybutynin. This is a bladder-specific anticholinergic that works by blocking muscarinic receptors in the bladder wall, which helps suppress involuntary detrusor muscle contractions. That leads to fewer episodes of urgency and urge incontinence and improves bladder capacity. It is considered a first-line treatment for overactive bladder and is a go-to pharmacologic choice for urinary frequency and urgency. Now, here's why the other medications are not appropriate in this case. Option A, benztropine, is indeed an anticholinergic, but is primarily used for managing extrapyramidal symptoms and Parkinsonism. It does not have any role in bladder control. Option B, glycopyrrolate, is used for reducing secretions, especially before surgery or in palliative care. It is not selective for bladder receptors and would not help in managing urinary urgency. Option D, tiotropium, is a long-acting anticholinergic used in respiratory care, specifically for chronic obstructive pulmonary disease. It acts on airway receptors and has no effect on bladder function. When it comes to NCLEX, always associate oxybutynin with urinary urgency, frequency, and incontinence linked to overactive bladder. Also, keep in mind the common anticholinergic side effects, like dry mouth, blurred vision, and constipation, especially in older adults, where cognitive effects may be more pronounced. And that brings us to the end of today's deep dive into pharmacology of blood and blood products. We hope those 15 questions gave you the boost you needed to feel more confident, more prepared, and one step closer to crushing the NCLEX. But don't stop now. We're just getting started. We drop brand new high-impact videos every single day, each packed with the most tested topics, must-know questions, and smart strategies that make your prep faster and more effective. So if you're serious about becoming a nurse, and we know you are, follow us, keep coming back daily, and let's cross that finish line together. Your NCLEX success story is just one video away.